Hi, this is Stuart Winkler. I'm a GYN Oncology Fellow at Walter Reed and an Assistant Professor in the Department of Obstetrics and Gynecology at USUHS in Bethesda, Maryland. I wanted to do a little talk today just to help OB/GYN residents prepare for their CREOGs in 2022, and this will be a GYN Oncology topical review. So I got a lot of the information for this talk from a couple of resources. One is the ACOG Countdown to CREOG, and another is the SASCOG's Pearls of Excellence, which I've used quite a bit in the past, as well as questions from question banks and that sort of thing. The approach would be just to address 10 topics that cover sort of the wide range of GYN oncology, and I kind of am doing this in pairs, where we talk a little bit about a pre-malignant lesion and then talk about the cancer associated with it. So we'll start off talking about adnexal masses, and then we'll go into ovarian cancer. So when you think about adnexal masses, and when you think about these with your question stem or whatnot, you want to have a differential diagnosis, and we tend to go immediately to the GYN reasons for an adnexal mass. We have the benign reasons, of course, your functional cyst in a reproductive age woman. You can have neoplasms like serous or mucinous cystadenomas, endometriomas, other infectious etiologies like TOAs, ectopic pregnancies, and whatnot. Typically, that information is going to come from your question stem, and it will sort of point you in the right direction. Of course, on the cancer side of things, we have our malignant neoplasms as well, epithelial, germ cell, and sex cord stromal, and all of the various subtypes within that. But you can't forget about the non-GYN reasons, and so there can be benign ones, infectious or non-infectious. There could be neoplasms, and then malignant ones as well, such as metastasis to the ovary from gastrointestinal tumors or other retroperitoneal sarcomas and whatnot. So you always start off with a history and physical, but we'll just assume that you've done that. And then an ultrasound. And so these are some ultrasound findings that would raise your suspicion for these adnexal masses to be a cancer. So thickened septations or mural nodularity, solid components, papillary projections, all these things would be in your question stem and would point you towards a malignant process. And then you're going to order some tumor markers. So CA125 is certainly the most well-known one, but CEA can also be elevated in mucinous ovarian cancers. When we think about our germ cell tumors, like our embryonal carcinomas and those such things, HCG can be elevated. For granulosa cell tumor, which is a subtype of sex cord stromal tumors, your inhibin A or B can be elevated. Dysgerminomas, which are the most common germ cell malignancy, we see kind of a non-specific marker of LDH, but definitely something that's asked about on questions. And then you think about these young-sounding tumors, like your endodermal sinus tumor, which is also known as a yolk sac tumor, or the embryonal carcinoma again. These can have elevated serum alpha-fetoprotein. There's some others too, CA19-9, which is a pancreatic marker, and then HE4, which is one that's used for epithelial ovarian cancer, and sometimes it's paired with CA125 for some of these risk of malignancy calculators. And then you have what I call the fancy tumor markers, so your OVA1 or your OVERA test. These are proprietary and generally kind of expensive tests that you can do that really help determine whether or not you need to refer a patient to a GYN oncologist. A cheaper way to approach it is something called a risk of malignancy index. I used this one in my practice when I was a generalist. And this is something that's really used a lot in the UK, but it takes ultrasound findings such as multiloculated cysts, solid areas, whether or not the lesion's bilateral, whether or not there's ascites or any other intra-abdominal metastasis, and then their menopausal status, and then pairs that with a CA125 and gives you a risk score to give you a percentage risk of malignancy. So management, once you identify nexal mass, and we're assuming these are ovarian for the most part, a simple unilocular ovarian cyst that's less than 10 centimeters can be observed. We have good data from this, mostly out of the University of Kentucky, big trial out of there, and others that we know that these can be observed and typically are not have no risk of transforming into malignancy. And then in some patients, there may be a compelling reason to avoid surgery. So somebody with a shorter life expectancy or severe comorbidities. Surgery is a good option if patients have symptoms of pain or pressure, sometimes torsion. For complex ovarian cysts, particularly in older women, where something like an endometrioma isn't ruled out, surgery is the treatment of choice for both diagnosis and therapy. And then if they have elevated serum markers or pelvic fluid, and then sometimes it's right to refer these patients to GYN oncologists, and there are referral guidelines from the SGO and ACOG. For premenopausal women, if the CA125 is greater than 200, or if there's ascites on imaging, or abdominal or distant metastases, obviously. And then that other indicator, a family history of breast or ovarian cancer and a first-degree relative, just by itself is probably not enough to refer, but in combination with other risk factors may be wise to refer that to a GYN oncologist. For a postmenopausal woman, we have a lower CA125 threshold, but similar with ascites or a fixed mass on pelvic exam. These would all be reasons to refer a patient. So that was talking about a nexal mass. Now let's talk about the diagnosis and treatment of ovarian cancer. So ovarian is the deadliest GYN cancer, and about 1 in 70 women lifetime will be diagnosed with it. Age by far is the biggest risk factor, and this is always a CREOG question. But always also family history, nulliparity and infertility, and then a history of endometriosis as well, particularly for endometrioid and clear cell carcinomas. And about 15 women with ovarian cancer have a hereditary cancer syndrome. Most of them are BRCA, but some have Lynch syndrome. There are really nonspecific symptoms, but bloating, early satiety are really the ones that are things that clinicians should be kind of on the lookout for. Unfortunately, a lot of patients are diagnosed later in their disease because of these nonspecific symptoms. There is no screening test, and CA125s are not helpful for screening, neither are pelvic ultrasounds. So we mentioned before there are really kind of 3 flavors of ovarian cancer, the most common being the surface or epithelial ovarian cancers, the most common of that being a serous. Serous can be either high grade or low grade, and they both of those subtypes act quite differently. Mucinous epithelial cancers as well are common, less common than serous, but are definitely seen. When you have this, you really need to be careful that it's not a metastasis from the GI primary. Endometrioid and clear cell, as I mentioned, are often associated with endometriosis. And endometrioid can also be associated, or you can see sort of elevations in estrogen as well with those, although that's primarily your stromal tumors that do that. And then a transitional cell tumor, so these are your Brenner cell tumors, usually benign, but rarely can be malignant. Your sex cord stromal tumors, these are the intervening cells in between your germ cells and underneath your surface epithelium. The most common malignant one is a granulosa cell tumor. And then you can have these benign thecomas, fibrothecomas, fibromas, and then also malignant Sertoli lydate tumors. And again, a lot of these have hyperandrogenism and hyperestrogen And then you have germ cell tumors, often in younger women, the most common malignant one being a dysgerminoma, but also rarely yolk sac, embryonal carcinomas. And then you can have immature teratomas, which are malignant, especially in the higher grade. The most common benign germ cell tumor is a teratoma, and we see those pretty frequently. There are different age distributions for these different subtypes. Epithelial, you're typically going to have older women in their 60s, 70s, and even 80s. For germ cell, these are much less common, typically in younger women in their teens or 20s. And then your sex-cord stromal, often there's a bimodal distribution, at least for the granulosa cell tumor. You can have a juvenile type that's earlier in younger women, and then typically the adult type or the normal type that we see is in women over age 60, typically postmenopausal women. And then your Sertoli cells tumors are typically in women in their 30s and 40s. So how do we diagnose ovarian cancer? Well, we obviously start with a history and physical, do an exam, and then for the bloating and early satiety, sometimes you just, and over the course of the workup, patients get a CT scan. Some concerning findings include ascites, a mental caking, and lymphadenopathy. But you have to have a tissue diagnosis to diagnose ovarian cancer. And we don't biopsy the ovary, but in advanced metastatic disease, you can oftentimes biopsy a piece of omentum or a lymph node or a nodule of some sort. Sometimes you can get cytology from the malignant ascites, but even in women who have a diagnosis of ovarian cancer, the ascites can be negative, and so that's not always reliable if it's negative for malignant cells. And usually the diagnosis is made at the time of definitive surgery. So just to really simplify the staging, CREOG is not focusing on staging as much, I think, as they used to. And this applies pretty much to all the cancers we talk about today. Stage 1 is going to be the organ affected, so the ovary, the endometrium, the vulva. Stage 2 is going to be just beyond that organ, so what we would consider locally advanced. Stage 3 is going to be involving the regional lymph nodes, and stage 4 would be distant metastases. And that holds true for ovary. The mainstay of treatment for ovarian cancer is surgical debulking. So chemotherapy with 6 cycles every 3 weeks of carboplatin and paclitaxel. There are those patients that you cannot surgically debulk, and in those patients, sometimes we'll start with chemotherapy, do an interval debulking, and then give more chemotherapy in a neoadjuvant setting. There is no role for radiation therapy in ovarian cancer, but we do use in select cases, some additional therapies, including PARP inhibitors and bevacizumab, which is an anti-VEGF medication. And it's really important, and something that you'll see on CREOGs, that all patients with ovarian cancer should have genetic testing or be offered genetic testing for hereditary breast and ovarian cancer syndrome. Just wanted to mention a little bit more on a couple of those chemotherapy agents we've mentioned. So the first is carboplatin. It's used in a doublet with Taxol, and that's kind of our backbone of chemotherapy for epithelial ovarian cancers. It's a synthetic kind of a version of cisplatin, and it's an alkylating agent. So carboplatin sticks physically to the DNA, causes a bend and break in it, and inhibits the cell replication by that mechanism. As I mentioned, we use it in epithelial ovarian cancer, but also sometimes in gestational trophoblastic diseases, and endometrial cancer, cervix, vulva. It's really kind of a workhorse for us. It's typically, like I said, paired with paclitaxel, and given at an area under the curve of 5 to 6 every 3 weeks, or sometimes we'll give it at a lower dose weekly. The toxicity, these are testable for carboplatin, is going to include thrombocytopenias, hypersensitivity, it's particularly after the 8th dose. Paclitaxel, its mechanism of action is it stabilizes the microtubules and inhibits cell turnover in that way. We use it, like I said, for epithelial ovarian cancer as well as endometrial cancers. It's given at 175 milligrams per meter squared every 3 weeks, or sometimes at 80 milligrams per meter squared weekly in a dose-dense fashion. There are also dose reductions that we do for toxicity. One of the most common toxicities you'll see with paclitaxel is neurotoxicity, so particularly peripheral neuropathy. In the cases like with cervical cancer where it's paired with cisplatin, that can be worse, as both of those have neurotoxicity. You can see pancytopenias, alopecia, which can be really concerning for patients, and it happens 100% of the time with Taxol. You can get bradycardia with the administration, and also a hypersensitivity reaction. This is usually with the first dose of the drug, and it is due to the vehicle that the drug is dissolved in, not the drug itself. Something that I think is helpful when you're thinking about toxicities for GYN cancers is this toxicity bear. The ones I would focus in on for you are cisplatin. So if you see the little C's for the ears and the C's at the kidneys, that reminds you that cisplatin is ototoxic and nephrotoxic. For vincristine and vinblastine, which we'll use sometimes for GTD, you get some neuropathies. Bleomycin is particularly causes pulmonary fibrosis, and that's part of the BEP regimen that we'll use for germ cell tumors of the ovary. Doxorubicin, which is a drug that we use for sarcoma, can cause cardiomyopathy. This is not to be confused with liposomal doxorubicin, and this is important. Liposomal doxorubicin, or Doxil, is the brand name for that. It's a drug that we use sometimes for ovarian cancer. It has a lot of different uses, but even though it's doxorubicin, because of the way it's packaged, the side effects are much different for Doxil. So particularly, you'll get these palmar and plantar erythrodesias, which are these sores that you'll get on your hands and feet, and that's very characteristic for Doxil. Cyclophosphamide, which we don't use as much anymore, but was a mainstay for many years of treating ovarian cancer, can cause hemorrhagic cystitis, and then methotrexate, which we use primarily for gestational trophoblastic disease, can also cause some neuropathies. Recurrence with ovarian cancer is very common, up to 75% in women with stage 3 disease, and a median progression-free survival is about 1.5 years. And the treatment from the point of recurrence really depends on the platinum-free interval. So for women who, between their last dose of platinum and the recurrence, if that's less than a month, they're considered platinum refractory. If it's 1 to 6 months, it's considered platinum resistant. And women who are platinum resistant, we consider incurable from an ovarian standpoint, and really the goals of care shift to really just disease control. For women who are platinum sensitive, so at least 6 months of disease-free interval, and the longer that interval is, the better. They can be re-challenged with platinum and often can see better control and sometimes even cure of the disease. There are a lot of different types of chemotherapy that are used in recurrence. For platinum-sensitive disease, we typically use a doublet, so we'll use one drug, either Taxol or another drug, and combine that with a platinum. For platinum-resistant disease, we often will do just monotherapy or combine the monotherapy with like a bevacizumab, some sort of a VEGF inhibitor. There are other newer therapies called PARP inhibitors, which is kind of beyond the scope of CREOG review, but just know that PARP inhibitors really have changed the way that we manage the BRCA patients, the patients who are BRCA positive, and has really resulted in a great improvement in overall survival for those patients. So we'll shift gears now and talk a little bit about endometrial. So I'll start off with endometrial intraepithelial neoplasia and endometrial hyperplasia. So there's this classic old system that's probably still in a lot of your textbooks that looks at the histology of endometrial biopsy and classifies it either as simple or complex, or simple with atypia or complex with atypia. So the gland architecture being described as simple or complex, and the nuclei being described as atypical or with no atypia. And then classically, the risk of progression to endometrial cancer is described. I always learned it as kind of the penny, nickel, dime, quarter approach as far as the risk of having progression to endometrial cancer. And the problem is this really, there was some lack of correlation between different pathologists. It really didn't predict as well as we thought it did. So that's changed now to this endometrial intraepithelial neoplasia nomenclature. So we can still have benign endometrial hyperplasia. You can think about that as hyperplasia without atypia, and that oftentimes you can treat that with either hormonal therapy or just treat the symptoms. Then you have your EIN, which is what we think of. You can think of it kind of as complex atypical hyperplasia, what it used to be described as. But down there in the second box on this slide, there are specific criteria for EIN, which I'm not going to go into. And then beyond that is your endometrial adenocarcinoma with their back-to-back glands and the findings that you see with the actual carcinoma. Then the risk of progression to cancer with this EIN or no EIN nomenclature is pretty drastic. So this was an older paper, but it was published in Cancer and showed this is like what we call a Kaplan-Meier curve, which looks at the probability of who remained without cancer over the course of just 12 months. And you can see that about half of women with EIN progressed to cancer within 12 months of follow-up. Just talking a little bit about sort of this continuum of normal glands all the way to endometrial cancer. Typically, as you get a higher gland to stroma ratio, this is where the term hyperplasia is used. And then as you get to EIN, you have some more irregularity of the glands, and then typically you'll see glandular crowding, and then even atypia within the nuclei. For EIN management, you have to rule out concurrent adenocarcinoma, and it's important to note that if you have a patient with EIN and an ultrasound that has an endometrial stripe of greater than 20 millimeters, the risk of an underlying cancer in that case is about 70%. So this is important as you think about who should be operated on or who should be sent to a GYN oncologist. The standard of care is surgical management, so with a hysterectomy, usually a BSO, but this can be individualized in premenopausal women. There are some non-surgical management options, although again the standard of care is a hysterectomy, but progestin-containing regimens can be used, provided that you regularly sample the endometrium to rule out progression. Talking about endometrial cancer, it is the most common GYN cancer. 1 in 35 women will be diagnosed with endometrial cancer, And these risk factors are a lot more predictive than with ovarian. So this includes obesity and unopposed estrogen. There's also a predilection towards African American women and Hispanic women to have higher rates of endometrial cancer. About 5% of women with endometrial cancer have a hereditary cancer syndrome, such as Lynch syndrome. For the premenopausal women, the most common presenting symptom is heavy bleeding, and any postmenopausal bleeding or spotting in an older woman is concerning. If you just take all postmenopausal women together, the postmenopausal bleeding is associated with cancer about 10% of the time. So I think that's helpful when you're doing counseling, and just helpful to keep in your mind. 90% of the time it's going to be due to atrophy or a polyp or something like that, but 10% of the time in postmenopausal women, it's due to cancer. There is no screening test, but endometrial biopsy is a low risk and inexpensive test, and we do those all the time. So concerning findings on imaging include a thickened endometrium in a postmenopausal woman, or obviously an extrauterine mass or lymphadenopathy on CT. And again, it's usually diagnosed on biopsy. So there are different subtypes or different histologic types of endometrial cancer. And we'll talk a little bit about type 1 and type 2, but the most common by far is the endometrioid type. And then rarer types include serous or carcinosarcomas, mucinous types. So this is a little bit older classification, but I think it's still helpful for conceptualizing this. You have your type 1 cancers, which are the most common by far. This is going to be your low-grade endometrioid cancers. These are typically indolent, less aggressive. They're related to estrogen, associated with a high BMI, but also unopposed estrogen, so low parity or null parity. There is a presence of a precursor lesion, so EIN is that precursor, or hyperplasia with or without atypia. And then the genetic alteration that we see with type 1 is most commonly the P10 mutation. So P10, conveniently on chromosome 10, is a tumor suppressor gene. We rarely see a P53 mutation with type 1. Type 2, less common, but typically these women are older. The histology is usually serous or clear cell types. These are high-grade aggressive tumors, not related to estrogen. There is particularly a risk factor for black women with this. They're 2 to 3 times more likely to have these type 2 cancers than otherwise matched white women. BMI is not really associated with these type 2 cancers. Neither is parity. There's probably not a precursor lesion. Sometimes we'll see endometrial intraepithelial carcinoma, but that's not been well established. But 90% of these women have P53 mutations in one way or the other. And then a good portion of them, especially in the serous category, have HER2 overexpression. And so that can be helpful when we talk about treatment. So as I mentioned, black women are more likely to have non-endometrioid high-grade tumors. The most common cause of a hereditary endometrial cancer is the hereditary non-polyposis colorectal cancer syndrome or Lynch syndrome. These women have a 40 to 60% lifetime risk of endometrial cancer. And in about 50% of women with Lynch syndrome, endometrial cancer is the first cancer they get. So even though it's called a colorectal syndrome, endometrial is the first cancer in about 50% of women with Lynch. Treatment really depends on stage, histology, and particularly on risk factors. So the most common, so unlike ovarian cancer, where the most common stage at diagnosis is stage 3, for endometrial cancer, the most common stage is stage 1A. 75% of women are diagnosed with stage 1A cancer, which means it's confined to the uterus with less than 50% of invasion. The most common type, again, is endometrioid. And so really these cases are cured with surgery. We typically do a hysterectomy, a bilateral salpingo-oophorectomy, and then we take lymph nodes as part of the staging. The standard has been shifting more towards doing sentinel lymph nodes, but either sentinel or full lymph nodes are acceptable. Now for stage 1A with high intermediate risk factors, and we'll talk about what those are in a moment, or stage 1B disease, surgery is typically followed by radiation, cuff radiation. If you look at the NCCN guidelines for all of these, you'll see a lot of pluses and minuses, which means we really don't know what the best treatment is beyond surgery. We know surgery is an important part, but whether or not we add radiation or what the extent of the radiation is sometimes can be a little bit confusing. Now for stage 3 disease and stage 4A disease, we typically do surgery followed by chemotherapy and then plus or minus radiation. And then all type 2 endometrial cancers, or all serous clear cell tumors, are high risk regardless of stage. And then just as we talked about genetic testing with women with ovarian cancer, endometrial carcinoma should go under testing for MMR proteins, or MSI. So this is done on the tumor, and there's a triage algorithm for women who have MMR, or mismatch repair gene expression deficits, to have testing for Lynch syndrome. So patients with high intermediate risk, ones who might benefit from additional radiation therapy after the hysterectomy, it depends on which study you look at, but that typically involves age, grade, myometrial invasion, and whether you're looking at the GOG data or the PORTEC data kind of determines which patients get that radiation therapy afterwards. I'll talk briefly about uterine sarcomas. They're much, much less common than endometrial carcinomas. They're rare, only about 1,200 per year in the United States. They're mesenchymal origin, so they come from a completely different cell type, and they involve the uterine muscle or the endometrial stroma. And these include most commonly leiomyosarcoma, but also undifferentiated uterine sarcomas and endometrial stromal sarcomas. Usually carcinosarcomas we include with the endometrial type, although there's a sarcoma component to that. So leiomyosarcoma is found in about 1 in 600 women who undergo surgery for fibroids, and that is something that we talk about with our preoperative counseling. And again, for Black women, the incidence is about 2 to 3 times greater than in matched white women. There's a poor prognosis with these sarcomas, and at least 10% of patients have lung metastasis at the time of diagnosis. So it's important to note that a uterine sarcoma can't be ruled out on a negative endometrial biopsy, and that makes sense because the tumor's in the wall of the muscle, not in the endometrium. And then usually it's made at the time of surgery, the diagnosis is. For treatment for sarcomas, it's surgery with a TA-HBSO and resection of any extrauterine disease. We don't routinely do lymph node dissection on these. These often will spread by hematogenous spread, not lymphatic spread. These patients get post-op chemotherapy, usually with a doxorubicin base. Sometimes they'll get Taxotere and gemcitabine. That's another regimen that we'll use sometimes. And then consider radiation in special cases. So from endometrial, we'll move on to cervical, and I'll start off with the premalignant lesions of the cervix. So talking about the natural history of HPV, we will remember that HPV is a small enveloped icosahedral double-stranded DNA virus. and it is a sexually transmitted virus that infects over 80% of sexually active women. In order for HPV to take root, there has to be a break in the mucosa, and the basal cell is the cell that gets infected. Viral replication happens in those epithelial cells, and most women end up clearing the virus within about 2 years. For those women that continue to have the virus, those are the ones that are at increased risk of progression to cervical cancer. So about 50% of women who are infected with HPV are infected with the high-risk types, but again, 90% clear this high-risk type within 2 years. It's important to remember that persistence of HPV predicts progression. So we know from older data that probably wasn't collected very ethically that the 2-year persistence of HPV-16 is associated with a 30% risk of CIN3 plus over 5 years. And then 30% of untreated CIN3 will progress to cervical cancer, while only 1% of treated CIN3 will progress to cervical cancer. So that's why treatment with a diagnostic excisional procedure or a hysterectomy is so important. So when we talk about dysplasia, there's some terminology that can get a little bit confusing. I think the important thing to remember is that when we have cytology and histology. So cytology is what we get on a PAP. Histology is what we get on a cervical biopsy. Cytology is typically described as L-cil or H-cil. The histology is described as CIN 1, 2, or 3. And then we've kind of gone away from the severe dysplasia, carcinoma in situ difference, because it can be hard to, again, for that to be consistent between multiple pathologists. The treatment of HSIL or CIN starts off with a colposcopy, and then if it's discovered, a diagnostic excisional procedure, and then we follow these up with HPV testing at 6 months and kind of follow the algorithm based on whether we have positive or negative results at that point. I wanted to talk about adenocarcinoma in situ. This is kind of a special case. Often there's no visible cervical lesion, and it can cause a little bit of a diagnostic conundrum sometimes. So oftentimes it's suggested on an AGUS PAP, so atypical glandular cells of uncertain significance. Of all women with AGUS PAPs, 3 to 4% will have AIS. And then among women with AIS, about over 50% will have a comorbid squamous lesion. So sometimes you'll find both an adeno and a squamous component. Both cold knife cone or LEAP, both are acceptable. I know classically we would say adenocarcinoma is treated with a cold knife cone, and that's because it has a lower risk of positive margins, but certainly a LEAP can be acceptable in some settings. If your margins are positive after a diagnostic excisional procedure, the risk of recurrent AIS is about 20%, and the risk of if it's negative, your risk of recurrent AIS is about 20%, and the risk of an underlying adenocarcinoma is less than 1%. If margins are positive for AIS, the risk of recurrence is 50%, and the risk of underlying adenocarcinoma is about 5%. So this is why often women with positive margins for AIS at the time of a cold knife cone will undergo a re-excision. And so there's kind of a management algorithm for that, depending on whether or not your margins are positive or negative. Going on to cervical cancer, thankfully the incidence has declined steadily in the US, but it has started to plateau. About half of the new cases of cervical cancer present at a late stage in unscreened patients. This is usually an HPV-related cancer. HPV 16 and 18 are the most common, and there's about 13 others that we'll see as well. And the risk factors include patients with sexually transmitted infections, smoking, and HIV. The PAP test has been a success for the medical field. It saved about 7 million lives since its introduction in the 50s. And the HPV vaccine will save even more lives. It's about 15 years old here in the United States, and we're already seeing some positive results from that. So the majority of cervical cancer is going to be squamous, about 75%. About 20% are going to be adenocarcinomas. And some of these adenocarcinomas are actually HPV independent. So clear cell, for instance, is typically HPV independent. There's a gastric type adenocarcinoma, also HPV independent. Usually mucinous and endometrioid, though, are HPV associated. The adenocarcinomas are more likely to have HPV 18, typically squamous or HPV 16, but it's actually about, for adenocarcinomas, it's actually about split between 16 and 18. It's just if you have HPV 18, you're more likely to have adenocarcinoma. There are other rare types of histologies, including neuroendocrines and small cells and mesonephric types, also another HPV-independent type that are much rarer. Most of what we see are squamous cell carcinomas. So treatment, just this is really simplified, but if it's microscopic, so 1A1, less than 3 millimeters of invasion and no lymphovascular space invasion, in this select population, a simple hysterectomy is acceptable because the risk of disease beyond the cervix is very, very low. If it's confined to the cervix and less than 4 centimeters, so this would be your 1A1s with LVSI, your 1A2s, your 1B1s, which are visible lesions less than 2 centimeters, or 1B2s, which are visible lesions 2 to 4 centimeters. Those can all be managed with a radical hysterectomy. So this is a hysterectomy that removes the uterus and cervix and tubes, and then the upper portion of the vagina, the middle portion of the uterosacral ligaments, and then the uterine artery, typically out to either its origin or at least to where it crosses the ureter, and all that parametrial web tissue in between. If it's greater than 4 centimeters, if the lesion is greater than 4 centimeters and still confined to the pelvis, we can treat with radiation therapy, typically with cisplatin for sensitization. And then for metastatic disease, it's really just chemotherapy. So surgery, like as I said, a radical hysterectomy, we do these open now. There was a large trial that came out about 3 years ago that showed a lower survival for those women who had minimally invasive radical hysterectomy. So the practice has changed to do these hysterectomies in an open fashion now. Oophorectomy is not a part of staging, and in fact, the average age of a woman with cervical cancer is about 38 years old, and so we often will preserve ovaries in these patients. Sometimes we'll PEX them out of the pelvis with the idea that we could maybe protect them from the radiation field if they need postoperative radiation. We can do sentinel or full lymphadenectomy as well for ovarian identification of stage 3 disease. Just a note on staging. Staging for cervix has changed recently. Lymph nodes are now part of the staging. They weren't prior to 2018, but that's changed. Set those criteria for postoperative radiation. So these are select groups of patients who benefit from additional radiation after their hysterectomy. And this has to do with lymphovascular space invasion or the depth of invasion of the tumor, and then also the tumor size. For radiation therapy, this really is the mainstay of treatment for locally advanced disease, tumors greater than 4 centimeters. Um, and so typically, the typical dose is 85 to 90 gray divided between whole pelvic radiation, which is typically given 5 days a week over about 7 weeks or so, and brachytherapy, which is used with devices such as the tandem and ovoids or the tandem and ring, where these are placed within the patient and a radioactive source, usually iridium-192 or a related radioactive source, is used to deliver the radiation directly to the organ that's affected by the cancer, so directly to the cervix and to the parametria. Brachytherapy is important. It's associated with improved survival on these patients. There's decreased utilization nationwide because it's cumbersome and you need specialized training to be able to do it well. The time to completion of chemoradiation is important as well. Survival is better if you complete the chemoradiation within 8 weeks. And as I mentioned before, we usually give weekly cisplatin as a radiation sensitizer. Speaking of cisplatin, this is another alkylating agent similar to carboplatin. It makes covalent bonds between the guanine residues in DNA and the platinum atom, so it distorts the DNA helix. It puts about a 20-degree or so bend in the helix and prevents replication by breaking the DNA. We use it in a lot of different GYN cancers. Regimens can be given usually IV, although it can be used intraperitoneal as well. And then toxicity, as we mentioned with the chemo-bear, ototoxicity and neuropathy and nephrotoxicity are really common. Nausea is very common, although we do a pretty good job of managing it with patients. And then myelosuppression as well. One more note on cervix are these Peters criteria for post-op chemotherapy and radiotherapy. So you can think of this as the 3 Ps. But if you're given within your question stem a patient who has a radical hysterectomy and they either have positive margins, positive nodes, or positive parametrial involvement, what's the next step? For these patients, they get systemic chemotherapy and radiation therapy. So moving on from cervix to the vulva, we'll start off with the premalignant lesion, so vulvar intraepithelial neoplasia. So there are kind of 2 varieties of this. There's the vulvar H-cell. This used to be called the usual type VIN, and then there's differentiated VIN. And so you can think of vulvar H-cell as being HPV related, typically in younger women. Your differentiated VIN is associated with things like lichen sclerosis and typically in older women. So vulvar H-cell, it's HPV-16 associated. Like I said, usually younger women, often smokers. There's a strong P16 staining, and then they typically don't have P53 alterations. About 22% of the time, this is associated with an underlying cancer, so this is not something that we can miss. These need to be biopsied and excised. Cancer can present with multifocal disease and also associated cervical dysplasia. These do have a better prognosis, probably partially owing to the younger population. Now, vulvar L-cell, so the low grade, is usually not an oncogenic HPV type. It's usually HPV-6, which is part of the 9-valent HPV vaccine, but is associated with genital warts. It's not thought to be a cancer precursor, except that you can rarely get what's called a verrucous carcinoma, but that's pretty uncommon. So that's the vulvar L-cell H-cell. There's differentiated VIN, so you can think about these as being associated with these vulvar dermatoses, so usually lichen sclerosis, but it can be anything that causes chronic irritation. So if it's chronic infections or vaginal dryness, all those sort of things. So older women, typically obesity associated, although not always. And then oftentimes you'll have a p53 alteration, but p16 is normal. And cancer usually presents with a unifocal lesion in these cases. So you can prevent VIN and prevent the vulvar cancer by treating underlying vulvar dermatoses. So if you treat them, they reduce the risk of progression to vulvar carcinoma. And then HPV, again, things that we can do to prevent HPV, including vaccination, should help. And then always, as with everything except endometrial cancer, smoking cessation helps. For VIN treatment, surgery is the preferred treatment for most. So for unifocal disease and those at risk for invasion, you really want to do a wide local excision with at least half a centimeter margins around the visible disease. We sometimes can do ablative treatment in select patients. So if it's multifocal or near sensitive areas, or the patient's at low, has been extensively sampled and is at low risk for invasion, you can do ablative procedures. Sometimes we'll use like the helium-driven plasma laser. We'll use a CO2 laser. There's different ways you can ablate the tissues. Same margins though, you still want to ablate the tissue at least a half a centimeter around the visible lesions. And then in carefully selected patients, sometimes you can use medical treatment like topical imiquinod. And then you'll see it in your questions sometimes about 5-FU. Clinically, we don't use that. That's incredibly irritating. If anything, we'll use this Aldara or imiquinod. It has to be in the patient who's willing to do treatment for 16 weeks, and then you would need repeat assessment and biopsies. Typically, they apply this every other day. Recurrence rates with VIN are high, up to 50%, especially if you have positive margins after a wide local excision. Patients remain at risk and need follow-up visits at 6-month intervals within 5 years of treatment and then annually afterwards. And again, preventing it with smoking cessation and the HPV vaccine is important. So on to vulvar cancer. It's one of the rare types of GYN cancer, only about 6,000 new cases each year. And the median age is 68, but typically women will be older or younger. So again, those precursor lesions like we mentioned, so the vulvar HSIL versus the differentiated VIN are precursors for the kind of two different types of vulvar cancers that we get. So younger women are more likely to have the HPV-related cancer. Excuse me. And cancer in older women is related to the vulvar dermatoses, just like the precursor lesions. Histologic classification, squamous cell by far is the most common. Melanoma is the next most common. And then rarer types such as basal cell or extramammary Paget's disease. Rarely sarcomas or adenocarcinomas, which you can see. I think this is important. Sometimes you'll have a question about a Bartholin's gland in a woman who's 60 years old. The answer is not to marsupialize that. You want to make sure that you excise those glands because there's a risk of adenocarcinoma at the base. Paget's disease, this is always a question, and there's this pathognomonic cake icing that you'll see kind of on the surface of this velvety lesion, and that's just classic and is oftentimes a question on CREOGs. Treatment depends on the stage. So if it's less than a millimeter of invasion, it's a 1A lesion. You can just treat with a wide local excision with a 1 centimeter margin. For a deeper invasive disease that's less than 4 centimeters, a wide radical excision with inguinal lymphadenectomy is appropriate. For larger lesions, so larger than 4 centimeters, usually radiation and chemotherapy. It's helpful that these are the same numbers that we use for cervix. It's a different process, but it happens to be the same numbers, so that's helpful, I think, to remember. For disease that is advanced but still within the pelvis, we can use radiation and chemotherapy. And then, unfortunately, for metastatic disease, it's usually chemotherapy and just some supportive care. The surgery that we do for early disease is typically a radical vulvectomy. The one common question is about when to decide which lymph node beds to sample. So if the lesion lies within 2 centimeters of the midline, you need bilateral lymph node evaluation. That's important to remember. And post-op radiation for positive margins or positive lymph nodes is employed. Vulvectomy is a very morbid procedure. You have a high risk of infection and breakdown, and patients need to be counseled as far as that goes. And oftentimes we get our plastic surgery colleagues to help us with repairs. Talk a little bit about gestational trophoblastic neoplasia. This is always a confusing one, so I'll spend a little bit more time on this one. When you think about gestational trophoblastic disease, you can sort of think about that as the big picture. And then GTN, which is your postmolar GTN, invasive moles, choriocarcinomas, and a couple of other rare types, is all sort of a subset within the gestational trophoblastic disease. We'll talk a little bit about moles, which are, you can kind of think about it as a premalignant lesion. So this is an abnormal placental development with trophoblastic hyperplasia and villus hydrops. The fundamental etiology is excess paternal genome, and that's sort of the thing that drives the moles. We talked about bimodal distributions a couple times today. This is another one for molar pregnancies. So young women or women who are at the end of their reproductive years. A previous mole increases your risk of future molar pregnancy. Each previous one increases your risk by about 10%. Southeast Asian descent is a really strong predictor for molar pregnancies. And then there's some rare things like this familial recurrent hydatidiform mole syndrome. There's also a thought that maybe diet and socioeconomic status may have something to do with it. So there are really two types, a complete and a partial mole. Complete moles typically present with vaginal bleeding in the second trimester and marked elevation in their HCG. About 40% of cases present with an HCG greater than 100,000. Eukaryotype can be diploid or is diploid. Both are usually paternal. And then the path shows marked cytologic atypia. And then you have the cyto and syncytial trophoblast proliferations, edematous villi. And then these are P57 negative, and I'll talk about why that is. Your risk at postmolar GTN is about 15 to 20% after a complete mole, and the risk of choriocarcinoma is about 2 to 3%. So rare but frequently tested findings include hyperemesis, preeclampsia less than 20 weeks, hyperthyroidism, deglutinin cyst, and then this kind of snowstorm appearance on ultrasound. Those are all sort of buzzwords. And a lot of your side effects are due to that beta subunit of the HCG molecule. There's pituitary hormones. Ultrasound findings. So this actually does look like a snowstorm because this was when the term was coined back in the 80s. But now what we see are these sort of cystic, hydropic sort of looking lesions within your ultrasound image. Partial moles also can present with vaginal bleeding, usually as a missed abortion. With unremarkable HCG, usually not nearly as high as what you see with complete moles. An embryo is often present. These are triploid. And the path, you'll see both hydropic villi and small fibrotic villi, so it's kind of a mixed picture. P57 is positive, but it's difficult to distinguish that from hydropic SAB, and so sometimes you need a fish. The P57 is I always get this backwards, but it's a maternally, it's like a paternally imprinted maternal antigen that essentially, if you have both maternal and paternal components to the mole, you'll be P57 positive. But if it's purely paternal, it'll be negative. So that's a way to kind of differentiate a partial from a complete mole. But it can still be difficult to tell a partial mole from, like I said, a hydropic salve. So sometimes we'll do a FISH test for that. Partial moles typically have a kind of an enlarged placenta and fetal parts. The postmolar risk is much lower. It's only about 5%. We said for a complete mole it was 15 to 20%. The risk of choriocarcinoma is less than 1%. A couple of things you might wonder. So can you have like a twin with a normal fetus and a mole? Excuse me. You can. It's about 1 in 100,000 pregnancies, so very rare. And then what other abnormal pregnancies mimic a partial mole? So Beckwith-Wiedemann syndrome, Turner syndrome, trisomy 18 are just a few that can. And then how do we treat a molar pregnancy? Well, it's important to get a pre-op chest x-ray, and we'll talk about why that is. Labs, including a pre-op or pre-treatment HCG. Suction D&C really is the standard under ultrasound guidance. And then you use kind of a large suction cannula. Uterine massage is necessary to control the bleeding. You need to give RhoGAM for Rh negative patients, and a hysterectomy can be done in select cases, although you do need to still follow the HCGs afterwards. Medical induction is a no-no because of the risk of bleeding, and then postmolar surveillance is important. So how do you surveil a mole? So we get HCG levels every 1 to 2 weeks until they're negative. And once you're negative, for a partial mole, you can get a single, after you're negative, you can get a single HCG a month later, and if you're negative, you're done. For a complete mole, we get monthly HCGs until we have 6 months of negatives. So postmolar GTN is extremely rare once you have a negative HCG. So the risk is about 1 in 406 for a complete mole, and about 1 in 3,100 for a partial mole. So very uncommon to have postmolar GTN after even just one negative HCG. I think that's helpful for counseling and maybe even for a CREOG question. It's important that the patient has reliable contraception until resolution. OCPs are preferred. IUDs are contraindicated with the mole, and then the etonogestrel or the Nexplanon implants have not been as well studied. So we've talked a little bit about the premalignant lesion, so that was GTD. Now let's talk about GTN, the neoplasia side. So postmolar GTN, which is the most common form, how do we diagnose that? So this is a weird type of cancer, right? Because it is a cancer, but it's not diagnosed by tissue. And it's really one of the only cancers that's like this. We just diagnose this by the tumor marker. And so it's diagnosed by a rise in HCG of greater than 10% over 3 values in 2 weeks, or a plateau of HCG within 10% over 4 values in 3 weeks. And this is just a definition. This is just a definition. Some people used to use the persistent HCG for greater than 6 months. It's not used anymore. But then also the histologic diagnosis of choriocarcinoma is also a way to diagnose postmolar GTN. And you'll see an invasive mole sometimes, which is a molar pregnancy that's invaded beyond the myometrium. Vascular invasion you can see, and there's frequent mets to the vagina, vulva, and lung. The presence of villi differentiates an invasive mole from a choriocarcinoma. I think that's probably beyond CREOG level questions, but it's good to know. So for choriocarcinomas, these typically present with vaginal bleeding or persistent HCG elevations. They occur in about 1 in 20,000 pregnancies, but again, for Southeast Asian women, it's as high as 1 in 1,000. 50% occur after a term gestation, 50% are post-molar, and 25% are post-molar, and 25% are post-abortion. The risk following a complete mole is about 2 to 3%. So remember, post-molar GTN after a complete mole is 15 to 20%, so much more common. And then depending on when your pregnancy or what type of pregnancy you had, average of 2 months after a term pregnancy or more than 12 months post a molar pregnancy. So this can be a kind of a far out thing. And then the thing that differentiates again is that you don't see villi. You see syncytial and cytotrophoblasts, but no villi. Mets to the lung are extremely common. In 80% of choriocarcinoma, you have lung mets. And then to the vaginas, the second most common, pelvis, brain, liver. Micromets to the lung can be seen on CT, but not on chest x-ray. They don't affect the prognosis at all. And these are very responsive to chemotherapy. So we stage GTN. Essentially, it's kind of the simplest staging. So either confined to the uterus, outside the uterus, stage 1 and 2. Stage 3 is just lung mets, and then stage 4 is mets elsewhere besides the lung. And so we report it as the stage and then a risk score. So this is the GTN WHO risk scoring system, and you don't need to memorize the individual things here, but just know that your age, so the older you are, the antecedent pregnancy, so a term pregnancy is higher risk, the interval of months, so the longer since your last pregnancy, the higher your pre-treatment HCG, the larger the tumor, the more distant the metastasis, and the number of mets you have, and then your previous failed chemo for rescoring. All these affect what your score is, and it affects how you're treated. So for low-risk patients, you can actually do a second curettage for postmolar GTN, and there's a 40% cure rate with just doing a second DNC. That works best for patients who have a low risk to begin with. And then if your WHO score is low, so 4 or less, we can do single-agent chemotherapies with methotrexate. Now, this is not the same dosing that you give for an ectopic pregnancy. This is still a multi-day treatment, but it's single-agent. Or you can do actinomycin, which is a little less well-tolerated. For higher intermediate risks or choriocarcinomas, the recommendations are for either actinomycin D or you can go to multi-agent chemo. And then for those high-risk patients, so a WHO score of 7 or greater, we typically use a pretty complicated regimen called Emico, which has 5 different chemotherapy regimens. But still, even with that high risk, there's still an 80% cure. Overall cure rate, if you take all GTN together, is almost 100% for low risk, and even for your high risk is 95%. Follow-up, so the FIGO recommends monthly HCGs for 12 months, but some experts recommend 24 for metastatic disease. And then some women with appropriate counseling and follow-up are able to get pregnant afterwards. The last thing we'll talk about is hereditary GYN cancer syndromes. I think this is pretty high yield for CREOG, so I'll try to point out the things that are particularly helpful. So oncogenes and tumor suppressor genes, if you remember, oncogenes, you can kind of think of this as a gain of function mutation. So, these are kind of a stuck accelerator sort of a problem where these genes get turned on and they result in proliferation. Usually these are not hereditary, and that's because these are typically dominant, and you don't need like a two hits for this. The most common one that we talk about with GYN cancers is the HER2 oncogene, RAS as well, sort of sarcomas and whatnot. But really the most common one that you'll see on question stems is going to be HER2. Much more common reason for GYN cancers are the problems with the tumor suppressor genes. Now these are often hereditary syndromes, and you can think about this as kind of a loss of the brakes, right? So this is a mutation in a tumor suppressor gene is like a car that's lost its brakes, and so these tumor suppressors don't do their job, and the cells continue to proliferate. So BRCA, hereditary P53, so Li-Fraumeni disease, retinoblastomas, and then all of your Lynch syndrome. All of these are tumor suppressor gene problems. So test taking tips here. If it isn't HER2, it's probably a tumor suppressor gene. And if the mutated protein is a kinase, it's probably an oncogene. If the mutated protein is a phosphatase, it's probably a tumor suppressor gene, if you just don't know what the gene is. And then very generally, kind of going along with this, kinases are activate, again, kind of the way oncogenes work, and phosphatases inhibit or suppress. So the primary ones we talk about that affect GYN cancers are hereditary breast and ovarian cancer syndrome, or BRCA. We can think about it that way. There's actually hereditary ovarian cancer syndromes as well, but we'll talk about those in a second. Lynch syndrome, and then Li-Fraumeni, which is P53, Cowden, which is P10, and Peutz-Jeghers, which is a STK11 mutation, I believe. So I like this graph because it reminds us that for BRCA, obviously breast and ovary are affected. For Lynch, they're at increased risk for ovarian and endometrial cancers. Also these rare ureteral cancers and that sort of thing as well. For Cowden syndrome, so for the hereditary P10 mutations, they're at increased risk for breast and endometrial. And then Peutz-Jeghers is kind of a weird one. There's a rare cervical cancer called adenoma malignum that you'll see with that one, and then there's a rare ovarian sex cord stromal called a scatat tumor. So it's a sex cord tumor with annular tubules. And that's kind of a rare one, but it's also pathognomonic for Peutz-Jeghers, and so may end up on a test at some point. Talking about BRCA, we all know that they are at increased risk of ovarian cancer as well. Higher risk for BRCA1, it's about 40% for BRCA1 and about 20% for BRCA2, if you just have to pick a number. And then BRCA2 obviously has other associated cancers, particularly melanomas and pancreatic cancers and those sort of things. They're also much higher risk for male breast cancer with BRCA2s as opposed to BRCA1s. One other thing about BRCA1, we think about like the Ashkenazi Jewish population as being really likely to have BRCA, but that almost all of that with that founder mutation is BRCA1, not BRCA2. There are hereditary ovarian cancer syndromes, and it's all part of this big homologous recombination deficiency sort of pathway. So in this little cartoon, BRCA1 and 2 are part of this, but there's also these other proteins that you can have mutations in that cause problems with homologous recombination repair. So RAD51C, RAD51D, and BRIP are all common, or not common, but are all specific mutations that you can have that increase your risk of ovarian cancer. So when we talk about risk-reducing surgery for risk of ovarian cancer, the timing is a little bit different depending on the mutation, and I think this is testable. So for BRCA, we typically recommend a risk-reducing BSO by age 35 to 40 because their risk of ovarian cancer is a little bit earlier in BRCA1 than in BRCA2. For BRCA2, the NCCN recommends a risk-reducing BSO by age 40 to 45. And then for these rare mutations, so the BRIP1s and the RAD51Cs or Ds, these are a little less well known, but are hereditary ovarian cancer mutations. The timing of risk-reducing BSO is a little bit later, age 40 to 45. Just a note for BRCA1, it's just a discussion to have with patients about whether or not to do a hysterectomy at the time. Women with BRCA1 are a little more likely to have a serous uterine cancer. It's still not a very high percentage. It's still maybe 3% or so, but a serous uterine cancer. And so some women elect to undergo a hysterectomy to reduce that risk. Talking about Lynch syndrome, like I said, this is primarily known for being a colon cancer syndrome, but also really common for endometrium. And if you look over at the mean age of onset, for colon, it's 44 to 61 years, and for endometrium, it's 48 to 62 years. So, like I said before, about half of women will have their first cancer be an endometrial cancer with Lynch syndrome. Women with Lynch are also at increased risk for ovarian cancer, about a 10% or so lifetime risk. You can think about it that way. And then also some rare things like I mentioned, the urinary tract, and then some strange things like the sebaceous neoplasm and such. So what do we do about risk management for endometrial and ovarian cancer with Lynch? There's not a lot of evidence here. There's no evidence for endometrial biopsies, but we consider doing those starting at age 35. And there's no evidence that risk-reducing hysterectomy improves the mortality, but it does decrease the risk of endometrial cancer, and so that is an option. For the ovary side of things, we consider risk-reducing BSO when patients have completed their childbearing for MLH1 and MSH2 mutations. For the other mutations, there's insufficient evidence. And then you could consider transvaginal ultrasound and CA-125 for women who still want to maintain their fertility, but again, kind of limited evidence on these things. So I hope this was helpful. We went through these 10 topics having to do with GYN, GYN oncology in preparation for the CREOGs, and I hope this helped you guys be ready. Thanks.